In this class, we'll discuss about methemoglobinemia. This methemoglobinemia, what does it mean? Normally, hemoglobin in a normal person, hemoglobin will have Fe2 plus in its structure. This Fe2 plus will bind with oxygen. But in methemoglobin, instead of Fe2 plus, they will have Fe3 plus. There will be an oxidation of Fe2 plus to Fe3 plus. And this Fe3 plus, they cannot bind with oxygen. And this decreases oxygen carrying capacity to the tissues. So this conversion of Fe3 plus can be reverted back to Fe2 plus with the help of an enzyme called as cytochrome B5 reductase. This cytochrome B5 reductase can use two reducing equivalents. One is NADH and one more is NADPH. This NADH will come from glycolysis and this NADPH comes from HMP pathway. With the help of enzyme glucose 6 phosphate dehydrogenase, which is a major enzyme in a HMP pathway which causes synthesis of NADPH. So this enzyme helps in reducing Fe3 plus to Fe2 plus and which prevents methemoglobin formation. Now we will see the causes for methemoglobinemia. These causes can be due to inherited one or due to acquired one. In the inherited one, this can be due to NADH cytochrome B5 reductase enzyme mutation. So this is mutation in cytochrome B5 reductase, and this mutation can be of two types. One is type 1, another one is type 2. Type 1 is seen only in RBC. Only RBC cells are affected. Only RBC are affected. But in type 2, all cells express mutated enzyme. In type 1, only RBC will have that. In type 2, all cells will express this mutation. One more mutation is any mutation in alpha globin chain, any mutation in beta globin chain. That means in this, tyrosine will replace histidine so that they will form a abnormal hemoglobin, HbM, methemoglobin, and this mutated hemoglobin cannot bind with oxygen. They will form methemoglobin. So they will have Fe3 plus. And G6PD deficiency will cause methemoglobinemia. And in acquired causes, drugs will cause methemoglobinemium. Which drugs will cause? Benzocaine, prilocaine, aniline, dapsone, nitrates, amyl nitrate, nitroglycerin. These are the drugs which come under nitrates. They can have effect. Primaquine, sulfonamides, rasburicase, which is used in tumor lysis syndrome, can cause methemoglobin formation. Phenazopyridine can cause methemoglobin. These are the drugs which will cause formation of methemoglobin, and benzocaine is the most common local anesthetic which is used for endoscopies. Is the hospital based toxicity where most of the patients experience methemoglobin formation. And reactive oxygen species can also form Fe3 plus and causes methemoglobin formation. So these are the causes for methemoglobin formation. And one important thing is newborns are more susceptible to methemoglobin formation. Why newborns are more prone to methemoglobin formation? Because RBC will have the half enzyme capacity to reduce methemoglobin. That means the enzyme activity is only 0.5%. So these newborns are more susceptible to methemoglobin formation and methemoglobinemia. So what will happen in methemoglobinemia patients? This presence of iron in ferric state, that is Fe3 plus state. What it will do? It causes oxygen dissociation curve to, they will shift curve to left. That means oxygen delivery to the tissues will be decreased. If methemoglobin levels are increased in the body, then oxygen cannot be released to the tissues. So the curve, ODC curve, will shift to left and they will cause hypoxia. Next, what are the clinical manifestations which you will see in methemoglobinemia patients? Normally, methemoglobin has to be expressed in percentages. It should not be expressed in gram per deciliter. It should be expressed in percentages. So it has better the percentages are better to express, and it will give the severity of the condition. How it is calculated? Methemoglobin, which we measure, and it has to be divided with patient hemoglobin, and you have to multiply by 100. If patient is having 1.5 gram per deciliter methemoglobin and patient hemoglobin is around 15 gram per deciliter, and the percentage of methemoglobin will be 10%. And if the patient hemoglobin is 8 gram per deciliter, then the percentage of methemoglobin will be around, if it is 1.5 gram per deciliter, we'll see the severity here. So the percentage of methemoglobin will be 1.5 by 8 into 100, then what will happen? This is 150 by 8. 8 ones are 8, so this will come around 8, 70, 8, it's a 64, 18 something, 18% will be there. Okay, so if you subtract 1.5 grams per deciliter methemoglobin in a patient hemoglobin, for a 15 gram per deciliter patient, if you subtract 1.5 minus 1.5 gram per deciliter methemoglobin, you will have 13.5 gram per deciliter effective normal hemoglobin. So patient doesn't have that much symptoms. With the 10% methemoglobin, patient doesn't have that much clinical manifestations. If you take the patient with 8 grams per deciliter minus 1.5, the effective hemoglobin will be 6.5 grams per deciliter, and patient will have severe symptoms also. He will be in a critical condition. This person will be in a critical condition. Okay, that means if patient is anemic patient will have more severe disease. Okay, next, organs with high oxygen demand like CNS and CVS are the first systems to manifest toxicity. So most of the symptoms are related to CNS and CVS. For a normal person, methemoglobin is less than 1.5% of total hemoglobin. And if patient is having 20%, if a normal hemoglobin person is having 20% methemoglobin, then the patient will have slate gray cutaneous discoloration, cyanosis, that is bluish discoloration of skin, and if you see the blood, it will be chocolate brown blood. The blood will be chocolate brown in color. This is an important sign. Okay, next, if the methemoglobin percent is around 20 to 50%, patient will have dyspnea, exercise intolerance, patient will have fatigue, weakness, palpitations, lightheadedness, confusion, and patient can have syncope. And if the percentage is around 50 to 70%, patient will have dysrhythmias, that is arrhythmias will occur in the heart, and patient will have seizures, metabolic acidosis. Because of hypoxia, lactic acid will be developed and metabolic acidosis will occur. Patient will have coma. And if it is greater than 70%, then it is lethal. In congenital form, the baby will have slate gray cyanosis from birth. And patients with hereditary methemoglobinemia, they are asymptomatic. They will have only cyanosis. All other symptoms will not be there with congenital methemoglobinemia patients. If you measure partial pressure oxygen in methemoglobinemia patients, it is normal. Okay. Next, patients with alpha chain variant will have cyanosis since birth, but patients with beta chain variant will have cyanosis in later half. Of infancy. In later half of infancy, they will have cyanosis. And for diagnosis, co-oximetry is accurate for measuring methemoglobinemia. For identifying methemoglobinemia. Co-oximetry. Next, how do you treat this methemoglobinemia patient? You have to give intravenous methylene blue. What this methylene blue will do, it enhances NADPH cytochrome B5 reductase enzyme and causes conversion of Fe3 plus to Fe2 plus. So this methylene blue enhances NADPH cytochrome B5 reductase and it enhances conversion of Fe3 plus to Fe2 plus. But this methylene blue is contraindicated in G6PD deficiency, because in G6PD deficiency NADPH is not produced. If NADPH is not produced, and this enzyme will be inactive and it cannot convert Fe3 plus to Fe2 plus. So there won't be any use in G6PD deficiency. And methylene blue is the first line in the treatment of methemoglobinemia. It should be given in the dose of 1 to 2 milligrams per kg body weight, and it has to be dissolved in saline, and it has to be given in IV route. And if you give methylene blue to HBM patients, it is not effective. Not effective. And if you give dosage greater than 7 milligrams per kg body weight, then this methylene blue will have an oxidative property, and it increases methemoglobin formation. Methemoglobin formation will be increased if you give greater than 7 milligrams per kg body weight. And this methylene blue is a class 10 teratogenic drug. In pregnancy, you have to outweigh the risk and you have to use. In pregnancy, you can use ascorbic acid. And you have to use cautiously. In patients who are taking serotogenic drugs. In patients who are taking serotogenic drugs. Why? Because serotonin is metabolized by MAO, a enzyme. This enzyme is inhibited by methylene blue. This enzyme is inhibited by methylene blue and increases serotonin levels, and it will cause serotonin syndrome. In mild chronic methemoglobinemia, you can use oral medication. And in this oral medication, we can use methylene blue. It will be around 100 to 300 milligrams per day, and you have to explain to the patient that urine will turn blue in color. Okay, this you have to explain to the patient. Next, ascorbic acid. It will be around 200 to 500 milligrams per day. And if you give ascorbic acid for a longer term, it can cause oxalate stones in urine, and it will form oxalate stones in kidney, and you have to give riboflavin 20 milligrams per day. So these are the drugs which are given orally for mild chronic methemoglobinemia conditions. And if in acute conditions and where giving methylene blue is contraindicated, you can use the following treatment, that is exchange transfusion can be done, and you can use hyperbaric oxygen as a second line of treatment, where patient is not in patients who are not responding to methylene blue, or you can use in G6PD deficiency also. You can use hyperbaric oxygen and exchange transfusion. This is about methemoglobinemia.